striking thing here is that there is a big political divide when it comes to some of the macro issues related to healthcare, but very little separates Americans when it comes to the consequence. The left and the right feel the pain across the country and are making difficult choices that no one should have to make. As Mike alluded to, there's a great fear of bankruptcy. So there really is great commonality on these important issues and very little that divides us. The bottom line, there's a lot, I think, that can bring us together to solve this crisis. We plan to work with Gallup to continue to track the public sentiment and, unfortunately, the public's pain points. This is critical to inform policy and also measure impact moving forward. Much of what we know and experience in healthcare is based not only on our own personal experiences, but what we read in the newspapers, magazines, and certainly what we watch on TV. Our next guest is someone who has been helping the public cut through the complexity of healthcare for more than 20 years. Please join me in welcoming CNN's chief medical correspondent, Dr. Sanjay Gupta, for a conversation with West Health's Shelley Lyford.
Hey, well, good afternoon.
Thanks for having me.
It's great to have you back. We had a good conversation last year, and we thought that we'd continue that conversation today.
Thank you. Thank you.
So we just heard the Gallup survey results that came out this morning. We're so happy to see such great coverage in the New York Times and CNN on some of those really compelling and actually quite shocking facts. And I think one of the things that we learned that perhaps has been most jarring is that Americans borrowed $88 billion last year to help pay for medical expenses. What do you think?
It's really sad, you know, you travel around the world and you look at other healthcare systems, and you don't look at systems where people are constantly making this decision over whether or not they should get healthcare versus other basic necessities of life.
Yeah.
But that is, besides the medical impact of people foregoing care, I think, it's the emotional impact, the psychological impact. And, for most people, I think, what you don't realize is if you're not defined by illness in some way, if you haven't dealt with chronic illness, these numbers kind of wash over you sometimes. When we tell the stories and report on it from a journalism standpoint, sometimes they sort of wash over you. If you are dealing with chronic illness, it is the only thing you think about.
Right.
These numbers end up being the most important story that you may read, in a long time. So it's sad, and I think it's very clear that it doesn't have to be that way. There's probably no place that we can point to and say this is a place that absolutely does the perfect job in terms of controlling costs and all that. But with regard to what's happening here, a number like that really tells a story.
It's extraordinary.
Yeah.
And, another data point that came out last year at the University of Chicago NORC survey is that 4 out of 10 people are more afraid of paying for the disease that they have rather than having the disease itself.
That's crazy. And that is absolutely, for a compassionate-based system, which a healthcare system should be, a system that is targeting people in their greatest times of need and vulnerability. The fact that people are more worried about the impact on their wallet rather than the disease itself that could shorten or end their lives or their loved ones' lives there's some clear markers of how not to do things, and that's another one. I think, when we talk about patient empowerment, it's not just a euphemism, right? I mean, the idea that patients and potential patients, which are any of us, are going to ultimately, put their hands up and say, that's enough. I think these numbers sort of speak to that, because how else are you going to make change if people who are most affected by this are not the ones who are involved in decision making? You got a small minority of people who are ultimately making decisions for the majority, and the majority, they're the ones who are the most directly affected by these types of numbers. So again, I have the luxury, Shelley, of traveling all over the world, looking at healthcare systems, looking at some of the systems that he was just talking about, the OECD countries around the world, and you realize that it is possible to provide high-value care that is much more affordable, gives much more return, in terms of what people are paying for, and doesn't put people in these unbelievably precarious positions of having to risk bankruptcy, worrying more about how much it's going to cost versus the disease itself. It doesn't have to be that way.
Right, that's exactly right. So we talked a little bit about, you mentioned a compassionate system, compassionate healthcare system. Our healthcare systems are pretty much governed by a fee-for-service framework. And you actually operated last night.
Yeah.
And so you function in that system. How can we transition from that system to more of a value-based system where you can have more holistic care, where outcomes can be focused on rather than getting more care?
It's interesting. I think if you talk to anybody, and I think I put practitioners and providers and everybody into this bucket, that I think everyone looks at value-based care as a more logical, rational system in some ways. I think that's, and we're clearly transitioning toward that, whether it's certain sectors or certain providers, whatever it might be. I think what we always have to think about, though, as well, is, you get these well-worn ruts in terms of how things are done. And there's a lot of inertia that goes into a particular direction. And so then when you want to transition to something that maybe should have been a system that was present all along, you need to sort of anticipate, I think, a lot of the potential obstacles to that. Why wouldn't it work, or what might those obstacles be? And I think, sometimes as a journalist who covers this, that's sort of how we have to think. Because we're going to tell the story, we don't want to be too simplistic about it, but we want to make sure that we can anticipate where the viewer, or in this case, the patient's mind is going to go. So, for example, if value is the metric that we're using to sort of determine the care, who is sort of the recipient of that? The patient's the recipient of the value, but how do you assign the value then? Someone comes into the hospital for headaches, for example, goes through a variety of different types of procedures. Some don't work, but did they have no value because they didn't work? Is that part of medicine, sometimes trying things because we don't have a clear-cut diagnosis as to why someone might have a headache, whatever it might be, who then ultimately is benefiting from the value besides the patient. I think that's something that we have to figure out. I think holistically it makes sense, and at the end of the day, you want the patient to be the one who's getting value versus hospitals or providing systems sort of just getting value for providing more procedures or delivering more care. But what is the real problem that we're trying to solve, and does that solve, I think is the real question. We're going to head towards a value-based care system. I think there's no question. I think it makes it a lot less rocky if we can anticipate some of those problems and look at some of the other challenges that people have had, either within smaller systems or other countries, when they've made similar transitions.
Right. So it seems like there's a real culture shift that's going to have to occur?
There's a big culture shift, and we still deal with these different sort of silos within hospitals. So, someone comes in with back pain, which is a conversation I think comes up at every healthcare conference, right? Diffuse or not diffuse, epidural versus non-epidural. Do you use non-steroidals? Do you use opiate pain medications? Do these things not have value because they did not work? They did not solve the problem for the patient. Sometimes you'd love to have the diagnosis and the treatment very clear cut. But sometimes you have what are called diagnoses of exclusion, meaning we're not sure what it is. We've excluded these things, so it must be this.
Yeah.
And oftentimes it is the treatment itself that helps make the diagnosis.
Right.
We don't know what it is, but given that this treatment worked ultimately, this must be the diagnosis. The point is, Shelley, I think in order to get to that part of the patient's care, sometimes there's a lot of other treatment that is sometimes given.
Right.
In the United States, we obviously give a lot of treatment.
Right.
And we prescribe a lot of meds, and we perform a lot of procedures. As you may know, I mean, it's comparable to some of the other countries that were being discussed. So maybe it's not the amount of treatment overall that's the big sort of, differentiator between these other countries. It's how much we're charging for those various procedures. And that's what really, I think, has to change.
Right, exactly. Also, what about outcomes?
Yeah.
How are we comparing on outcomes?
Well, if you look at some of the most basic outcomes, we're not doing very well. I mean, look at life expectancy. I think it was just quoted 23rd. I think it's even actually lower than that. And by the year 2040, if all things stay the same, we're expected, I think, to be 63rd or something in the world with regard to life expectancy overall. So it's kind of nuts. We have dropped in life expectancy 3 years in a row now in this country, which is unbelievable. Last time that happened was 100 years ago, where we dropped 3 years in a row. You know what was happening 100 years ago is that we were in the middle of a world war and a global flu pandemic. So how does a country that spends, $3.5 trillion a year, more than any other country in the world, as everyone knows, continue to drop in life expectancy 3 years in a row? It just doesn't make any sense. So the big outcomes, the ones that will be measured on historically, we're not doing very well. Preventable diseases, I think 11th or 12th in the world. So these are clearly the things that people pay attention to, and the United States does not really shine through.
And you spend a lot of time thinking about life expectancy, and in fact, just last week, there was a wonderful premiere of your new HBO documentary called One Nation Under Stress. So congratulations on that amazing piece of journalism. And in that documentary, you actually explored why life expectancy is shorter in America than any other industrialized country, and the fact that we have an unprecedented number of deaths of despair. And I'd like you to talk more about that, but before we do, for those in the audience and at home who haven't yet seen the documentary, we have a brief clip. Okay. So why don't we just roll that clip for a minute.
What's the story with her? How old is
We cannot ignore the impact of stress on our society and what it's doing to people in very, very tragic ways.
In the United States, life expectancy is dropping faster than any other developed demographic in the world.
We're drinking more, we have a massive obesity epidemic, and uncontrollable chronic stress.
Liver cirrhosis, drug overdose, and suicide. They are called deaths of despair.
Knowing the cause of the cause is far more important to really understand what's happening.
Stress is an epidemic of monstrous proportions.
What's the surest way to make our have-nots feel poor? Put them in a lot of income and equity.
Not only do you feel helpless, you feel rage.
It just seemed like we didn't matter.
People have this ideology that competition is good for you, but that's a trick.
Could it be that a society gets so stressed out that it actually starts to break?
It's intense, right?
Yeah.
I was really blown away, I think, by the fact that life expectancy was dropping in this country, and I think as medical professionals, I think anybody, frankly, should find that unacceptable. The thing that really struck me, Shelley, I think, is if you start to look at other countries around the world, similar countries, wealthy nations, you find that they've continued to have an increase in life expectancy and a decrease in mortality, right? I mean, they've had the same economic pressures as us, they've had the same labor force pressures as us. So where does the story lie? What's different about the United States? Why is the United States the country where this is happening? And then even if you look inside the United States, three largest demographics, African Americans have higher mortality rates than whites, but the mortality rates have continued to come down. Hispanics have lower mortality rates than whites, and they continue to come down. It's mainly whites and mainly working class whites where life expectancy has come down and mortality rates have continued to go up. So if you look at every demographic in the developed world, since the last 20, 30 years, all of them have increased in life expectancy and decreased in mortality except for one. And that's what we're dealing with here. And the top three causes of these new increases in death were drug overdose, primarily opioids, suicides, gone up 30% over the last 20 years, and liver cirrhosis due to alcoholism. That's why they're called the deaths of despair. And it's tragic, but also presents a real opportunity, because when you start to look at data like this and you really get it inside your head, you better understand, I think, potential solutions to this problem.